Syndrome of inappropriate antidiuresis due to reset Osmostat in small cell lung cancer. Our learning objectives are to understand the clinical presentation, workup, and differential diagnosis for syndrome of inappropriate antidiuresis due to reset Osmostat, and to consider a rare pathophysiologic mechanism for SIAD. A 61-year-old woman with 30-pack-year smoking history presented with nausea, vomiting, and diarrhea 1 month prior to admission, and shortness of breath, orthopnea, and leg swelling 1 week prior to admission. On exam, her blood pressure was elevated to 218/117 with an S3 heart sound, bilateral crackles, and edematous extremities. Her labs were notable for a serum sodium of 115, serum hypotonicity to 243, urine osmo of 216, urine sodium of 44, FAUA of 11%, and Fe sodium of less than 1%. An AM cortisol was 17.8 and TSH was 2.27. CT chest revealed a mediastinal mass. Pleural effusion was diagnostic for small cell lung cancer. Further imaging revealed stage 4 small cell lung cancer with superior vena cava syndrome, a left frontal lesion, and liver metastasis. The patient was treated with chemotherapy, carboplatin, and etoposide. In the following months, she remained mildly hyponatremic at 133, 126, and 125. 7 months later, the patient developed nausea and vomiting with hyponatremia to 116. She was admitted, and following improvement in serum sodium from 115 to 133, her urine osmolality increased from 143 to 771. The patient was diagnosed with SIAD with reset Osmostat due to small cell lung cancer. This graph demonstrates that at low serum sodium, the patient was able to produce dilute urine with a urine osmolality of 100 to 200, and at a low serum sodium of around 125 to 124, the patient was able to concentrate their urine to around 400 to 600. The low urine osmolality was evidence of ability to dilute at very low levels of serum sodium, and yet, while the patient was still mildly hyponatremic, the urine osmolality was able to increase to very high levels. Reset Osmostat may not be as benign as discussed in the literature when due to malignancy. A possible mechanism for SIAD due to lung cancer is discussed.